Hello everybody, my name is Michala and I work for Suffolk County Council in adult care services as a digital care advisor. I'm here today to talk to you about how we utilised digital care technology to support Suffolk residents and in particular the elderly and the most vulnerable during COVID. So what was happening in Suffolk? So we recognised very quickly that our residents receiving care at home were at increased risk of exposure to COVID by having different carers in and out of their homes. We knew that with everyone having to isolate, it would mean that residents weren't able to have face-to-face contact with their friends and families, especially for those who are particularly isolated, and that the impact this could have on their overall well-being. So not only did we think about our residents, but we also were taking into consideration how we could maintain capacity in the care market as well, and how we would be able to sustain this so that those residents that really needed the care visits were not affected. So we needed to make sure that our care providers would still be able to go in and provide the care that was needed. So we knew that the infection levels were rising rapidly, and we knew we had to act quickly to ensure our residents in Suffolk were kept safe and well. So what we looked to do. So initially, we engaged with care technologists and market leaders to identify what offers were available. We commissioned Alcove and Rethink partners and worked in partnership with them to rapidly roll out a new technology-enabled service, which we called our virtual care response. So it was designed to assist the council, adult social care and care providers to continue to deliver care to residents virtually and help our residents to access support and live well during this difficult time. The service was not a replacement for necessary care visits, but it allowed residents to receive care virtually for identified tasks that didn't require hands-on support, like prompts and wellbeing checks, for example, but still while protecting them from exposure to infection. It also enabled people providing care to do so in a different way by reducing their infection risk, decreasing travel time, and enabling them to carry out their caring role while self-isolating, as well as help to free up time and resources within the care sector to support our most vulnerable adults. We rallied and engaged with our social work teams, care providers and digital care advisors from our key areas to identify the types of people who would benefit from the device, including those who were shielding, in receipt of care services, and those at most risk of social isolation and loneliness. We reached out to older people, adults with learning disabilities, people living with a mental health condition, carers, and their formal support networks. We set up a support network of frontline professionals, so our social work practitioners, who could support people to receive the devices. So they were quite important in this, in determining who was most applicable to receive the technology. So what the solution was. So you can see here a picture of what we actually provided to people. So it was a very simple lockdown tablet device. So the service was provided through the rapid rollout of the Alcove video care phone, which is what's shown here. So, as I said, it's a simple communication device that allows people with little or no technological ability to have two-way video contact with families and friends, paid care workers and other professionals. So those receiving the care phones did not need access to any other equipment or technology. So to use a video care phone and didn't even need Wi-Fi, as it was SIM enabled. So really reduced those people able to access it that didn't have that technology experience or no Wi-Fi at home. So once the device was delivered, all they had to do was simply plug it in and turn it on to get started. Alcove, our tech company, remotely configured the video care phone so that to the customer's needs and provided ongoing technical support. So they would add on all the contacts that the person would need. And as you can see, it's a simple just touch button on the screen to who they wanted to call. And by clicking on the tile on the care phone, the recipient was able to contact professional care support, contact up to 3 informal carers, such as family or friends, and contact Alcove technical support. So care workers and family members were given access to a portal through an app so that they were able to make the calls into the care phone and keep track of care phone activity and to ensure the recipient was staying well. So how were they used? So the devices were used to meet a number of different needs, which you can actually see illustrated here. Some of the video care call functions included medication reminders, an ability to actually visually see somebody taking their medications. We know that we can prompt people to take the medications. We haven't got that evidence they're actually taking them. So via a video call, we're actually able to see somebody physically taking their medications, which is reassuring to family and care workers as well. So we did use it for reminders and checks for other health needs. So if, for example, somebody needed to cream their legs, or if there were other medical things they needed to do, we could just set reminders up for them to do that. We used it for welfare and wellbeing checks. We knew that a lot of our care calls not necessarily needed that hands-on care, so we were able to do a video call to them to actually see if somebody was okay. And we know that actually visually seeing somebody, it gives us a better indication as to how their overall wellbeing is, rather than just a phone call. So we used it for reablement as well, so with our in-house home care service, so that we could use it to train people on basic daily tasks. So if it was somebody that needed that bit of rehabilitation, then we were able to talk them through some daily tasks that they could then actually complete themselves. We use it for social work assessments as well. So our social care practitioners at that time weren't able to go out and do face-to-face visits to carry out assessments, so they could do that by using the video care phone, keeping themselves and the resident safe. We also used it for daycare centre activities. So again, a lot of the residents weren't able to attend their day centres that they really relied on during this time. And they were able to actually still attend virtually. So they were able to engage and still be involved in those activities and see their friends that they hadn't been able to see. So really impactful there on how we've used it. So what have we achieved? So we are proud to say that we've achieved what no other technology project in Suffolk has achieved before. So we delivered over 1,200 video care phones to support people to stay in touch with their formal and informal support networks. We actually generated over 75,000 video calls between people and their networks, which was a total of nearly 300,000 minutes, which I think you can agree is quite an achievement there, in keeping people connected during this really difficult time. So I've got a few case studies here. I'm not going to go through them all with you, but they're just some examples here of how we can see the impact the video care phone had on people's lives. One of them on here that I've picked out particularly is Florence here, who is actually 104. She was using the video care phone to keep in touch with her family, and she said how easy it was to use, which really demonstrates how even for those with no digital skills and of the older generation, the care phone was designed so that it could be simple for them to use, and then it did not exclude them from being able to use the care phone. So that was really important, that we were able to include everybody being able to use this device. There's another story that really resonates with me that actually isn't captured on here, but there was a lady that was turning 100. It was her 100th birthday, and she wasn't obviously able to see and celebrate with her family. However, by having the video care phone, she was able to see all her family, and they had a virtual celebration for her, which she said was so special. So I think, yeah, being able to celebrate a very special birthday like that and being able to see your friends and family was so, so important. So just a nice one there to share with you. Just some examples here. So we have one of our day centres, got some pictures here of Pottsford Care Services in Suffolk, and it's showing one of their service users using the care farm. So he often used to go to the day centre and he enjoyed being with the animals and seeing the animals. So he was still able to do this using the video care phone during lockdown. Obviously, he wasn't able to have that physical touch, but he was still able to see them, which made a big difference to him. So Brian always looked forward to seeing the animals when he actually went to Pottsford, and being able to see them virtually, it really had a great impact on his well-being. And Brian actually said, it's a very good way to help me communicate and see people I can't go to see. It's very easy to use and would be good for anyone who lives on their own and can't get out. And then we had some feedback as well from Kevin, who's one of the care workers at Pottsford. And he said that the care phone has allowed them to work more flexibly and change the way they deliver services. So if this hadn't have happened, nobody would have thought that we could deliver services via a video care phone. So what have we learned? So we know that culture change remains the biggest challenge. The assumptions about tech appetite of vulnerable groups persists and can actually slow down the referral process, particularly amongst social workers. We did find that. But we also found that occupational therapists are often strong champions for tech. We knew that getting to the people who are closest to the service user and enabling them to recommend people for receiving the technology is really key. They know how people work, they know what their mindset is, so it's really important to get those involved at an early stage because they have the best understanding of people's needs and the situation and the best advocates for them and the technology. So engaging care market providers early and with purpose is key to getting the right referrals happening. Maintaining income levels and making it as easy as possible for them to engage was really essential as well. We had a dedicated communications team, and that has been a major requirement to adapt into situations which can change rapidly. So we needed to make sure that communication was getting put out in a timely manner. And then governance and decision making can take longer than planned. So even when there is fast track processes in place, which we did have, the processes aren't designed for this kind of pace and use case. And Care Act implications are resolvable, but need to be considered as well. So make sure you keep those in the forefront when you're doing anything like this. So the learnings from the COVID response has been pivotal in informing how we progressed with our digital care partnership in Suffolk. And it equipped us with the skills to ensure we were able to produce something amazing. So I'll just go on to talk a little bit about where we are now with that. So we have created GIES, which is our award-winning digital care partnership for Suffolk County Council. It offers a modern, cutting-edge care technology service to support people to live happy, independent and connected lives, which will blend in with mainstream technology and complement face-to-face care. The service provides personalised equipment and devices to address the specific needs of people and support them to live independently for longer. So we created a single place to order and fulfil all care technology, so it was easier for practitioners to have one place where they can get everything they needed. We trained all our care staff, our frontline workers, so they knew how to access the technology. They have access to expertise as well as developing a champion network within the social work teams. We had a catalogue of technology that we will develop over time as the service grows. And it's an end-to-end service. So from installation, as I said, the training we provide, ongoing support, and we collect the devices if they are no longer required. So it's a full round service from practitioner end to the service user end as well. So here you can see some of the examples of the technology that we provide of the GIES service. So it's a core range of the equipment that is shown here. So some of the items we have automatic falls devices, we have smartwatches, we have sensor kits, bed and chair mats, and we also have the Alexa Show, which can be used with smart bulbs and plugs to maintain people's independence. And of course, in the centre there, we have the video care phone, which has many new added features now to what we used in the virtual care response, and including being able to link to a Bluetooth Falls button, which is shown here in the picture. We also have items available that are more specialised. For example, we have epilepsy devices, language translators, and something called a reader pen, which, just to name a few of those that we have available as well. So the service is not just limited to these items. So as I said, the range of equipment will grow as the service develops. We know that technology is changing all the time, which is why our team of experts are constantly horizon scanning to see other ways we can improve people's lives and with technology to ensure we are always evolving with what's changing in the world. So our service so far, so the service has been operational since July 2021 after a really rapid service build. We are seeing significant levels of referrals with over 1,900 people referred to date, which is absolutely amazing, and over 3,500 devices have been deployed into people's homes, keeping them safe and independent. We've generated significant benefits in terms of outcomes, quality and savings opportunities. And we've actually seen 6 million in cost avoidance savings and 600,000 in cashable savings. And we have a 97% happiness rating, which we are more than pleased with. So as I said, the service will grow. This is where we're at the moment, but CASIUS will develop more and more over the coming months and years. So that brings me to the end of my presentation. I'd like to take this opportunity to thank you for taking the time to listen. And I hope that I have shared with you today, what I've shared with you today will help shape any technology projects that you may plan in the future. Thank you and goodbye.
Thank you, Michala, for the comprehensive presentation, and definitely we can feel the passion of Michala for her enhancing the quality of life of the residents with innovative technology. We are grateful to have her today with us as well. Hi, Michala.
Hello.
Thank you for your input. Yeah, nice to meet you. Thank you for your time, and we have some questions from the floor. But before the audience question, I would love to know that you come from, so you're working for the Suffolk County Council. So what do you think that the government or the district-based role or the local government role in taking this, especially under the COVID time? How this role actually empowers the work, or there is any barriers of doing it?
I think the main barriers, particularly, are our own workforce. Really, it's having that, as I said before in the presentation, it's that whole culture change piece, and getting them to adopt and take on board that change and evolve with it. Sort of from a government and a higher up perspective, I mean, we've done a lot of work with our local county councillors as well, and they've really embraced the work that we are doing and developing. They are aware, obviously, we are working with an aged population, so not everything suits everybody, but that's why we're trying to make sure that the service can meet the majority of people out there.
And I think that the local county actually take a very important or instrumental role in localizing the needs of people, and definitely that you can receive the reflection or the comments from the users. There's one question from the floor, that the project was primarily designed to maintain social connectedness of older people and other vulnerable groups in need during COVID-19. How would those platforms be transferable to post-pandemic time? Even probably we are a bit far from it, but how it is transferable to probably the near future?
Okay, so in the last part of the presentation, I went on to talk about HKCSS service. So that has actually transformed from that video care phone used for the COVID response. We have transformed and developed that device to form part of our larger digital service that we now offer. So the use of the video care phone itself has increased. So we're able to, we're doing we've got extra features on the care phone, so it links to a Falls button now as well. So not only using it as a communication device, we're using it linking to Falls wearables. We've accessed a web browsing element to it now as well, so that people can have use of the internet. And this will develop even more as we get that feedback from the service users as well, have those service user groups, what they actually want from the device, and getting other people's input into that as to the benefits that they can get. And if we can develop it and improve it, then we will do. So yeah, it just demonstrates that we have already taken it forward and are using it now as well.
Well, it is very important to bring the good things like ahead, so that it helps people to familiarize with the service you do, and at the same time, things they will be easier to adopt and to the service model probably you are promoting later. The other question is, you mentioned there are several groups of people using the virtual care support applications, including older people, adults with learning disabilities or different abilities, people with mental health conditions. Would you tell which group would be benefited most from it, from the work that you've done?
That's quite a difficult one, really, because I think it did benefit most user groups. But I think from the evidence that we gauged, I think those people that couldn't physically go to those day centres probably was the most impactful, because, you know, that was a big part of their lives, going out and seeing people, having that social interaction. And like the example I gave there with somebody with a learning disability, you know, that's a huge part of their daily lives, and not being able to do that, but still having that contact and still being able to speak to people and visually see people was a huge impact for them. So I would say probably, yeah, the day services element of it.
Right. I think that is something that we can learn a lot from to Hong Kong as well. The daycare center, they have basically they have the largest membership, and they get to approach the largest group of people, so that this is something that they should make use of. This is also where big data comes from as well. The next one is, among those video calls recorded, would you share how many were from family members, social workers, or therapists, healthcare practitioners? How good were the response from each of these groups?
Do you mean how well did they use it in terms of volume? Is that what you mean? Yeah, okay. Yeah, I mean, I would say predominantly it was friends and families keeping in touch with their loved ones, those that couldn't see. And I think, given the fact that it can be used internationally as well, so if there were people that had family abroad, they were able to use it as well, which was really, really beneficial. We didn't use it so much effectively with the social care practitioners, but I think that was because of the length of time that it takes to do an assessment virtually, and it's not always, you know, having to sit with somebody, having those long conversations with them via a video wasn't as effective when you're working with that older population. But I think definitely that communication with keeping in touch, and there's the care providers as well, definitely beneficial for them.
Great. Thank you. And I think that's all the questions that we have for you. And thank you, Michala, for your of your participation today. And we hope to meet you in person one day in our future work. And take care. And thank you.
Thank you.
Okay,
thank you. Bye-bye.
Thank you very much. I'm going to talk about technology and dementia. And this is the reason we're having this talk, because currently, this is my disclaimer, the current dementia care in many countries are different, but generally is about the family, friends, charity and volunteer organization, healthcare services, day center, social service, and care homes. And it changes from one country to another. It depends on the severity of the dementia and many other care that they have. Also, we heard a lot in the news and from different organizations about smart home and how a smart home could work, and some of the issues about people with dementia using a smart home. And all of those things made us think about how could we use the combination of those things. Before we get there, I think it's important to know that this is the new phrase that's coming into medicine, and it's very important into technology. So it's about using the technology and environment to promote independence. And it's a lot now that we use in the older adult psychiatry, in neurology for dementia and geriatric medicine. But why? Why do we need to talk about AI and computer and technology? And the reason is the human mind needs constant training, and the cost of human mind and cost of human training and resources is going up. I think this is one of the issues about providing care for people with dementia. Everyone is different. You can't compare many variables, and we look at variables that has been in the textbook, and therefore we need some system that could help us change the model that it works. This is a very typical example of what you see, that you could only look at one item at a time, but if you look at AI, it could give you at least thousands of different options at the same time. We're living in an era that the data is constantly going up, and this is the amount of data that we produce yearly. And if you look at some of those, I never heard of zettabyte before, but one zettabyte is like 1 billion DVDs. And you look at how much data we produce, and if we could bring those data into the healthcare and use the data everyone produce, like how many times you use your phone, how many times you turn your TV on, what the Google search use, and all those things could help us to look at the cognition of the person. So we designed a service that look using technology and AI all together at the same time. So what we did, we did a survey, and generally people, they said 85% they want to stay in their home as long as possible. They don't want to go to care home. They don't want to be transferred to some of the unit to be cared for. We also look at the current setting in hospitals in UK, and in 1 in 4 hospital beds currently being occupied by people with dementia. It's not just because of the dementia beds, it's when they have infection, when they have surgery, the length of time in hospital is much longer than any other condition. And we think this number will increase by 70% in the next 5 years. So in 5 years' time, we're going to look at maybe 2 in 4 beds in hospital are being occupied by people with dementia. And so the cost will go up and the use of care will go up. So we designed a service that it has to be personalized, because if you want to use technology without any personalized intervention, then we get into the problem of receiving so many alerts and so many issues. We know that the sleep disturbance is one of the major issues with people with dementia, because they can't sleep, they wonder, the carer can't sleep, and that's where the care is breaking down. Infection, agitation, and aggression, which one of the major neuropsychiatric symptoms of dementia, are very important, and social isolation. What we did, we gathered a group of people. We asked them to be their trusted users people. We started giving them technology so they could use in their home, and they could give us feedback about how things are. And then we used this knowledge to design a trial. What we did, we put a set of devices and technology in people's home. All those things are devices off the shelf, nothing very major or fancy. So we gave them blood pressure machine, we gave them pulse oximeter, we gave them some sensors that it goes on the door, the toilet door, the front door, the back door, the sensor that shows how many times they use the kettle, they open the door of fridge. The EEG device is so tiny, it goes in their ear, the medication, it just how they use the medication, open the bar or not. And also we've done some questionnaire, and we look at their pattern. All the data will come to a cloud. The AI now started cleaning up the data and bring it to the platform that it can be used. So this is a digital platform that we have. Every person has a platform. The platform is being monitored by assistants. So they're not clinicians that look at the data. And 2 people could monitor up to 2,000 homes. So the data will come here and we look at data. And anything that goes out of range, we get a notification. So we don't need to contact people on a regular basis. We only contact people if there is a notification. This is a chart that we get. So, and we ask people to use the devices as much as they want. And AI will help us to set up a personalized level for them. And if something goes out of the personalized limit, then we will be identified about it. So you could see that the blood pressure, we get the graph. And if they go to any other healthcare services, we provide a letter, or we could send them emails with all the graph and charts. So if they need to go to hospital for a hip operation, we could provide them lots of graph and information so they know the health of the person. They don't need to go to see their general practitioner regularly because all the information is here. But the important part is about the daily activities, is about how often they move in their house, the bedroom, the lounge, the living room, the front door, and all those things. It may look that we live in a different way every day, but all of us have a routine pattern of life. And we hardly go out of routine. And a tiny bit is not something that we call it anomaly. If you look at the second chart on the bottom, you could see that suddenly things have started to change. So the person is wandering more or waking up in the middle of the night more. And that's where we started to say, okay, something wrong with this person, we need to contact. Maybe there is an infection. Maybe there is something else going on inside the house. You could see that very easily with the graph that we produce, we could monitor people without even contacting them. And then if something goes wrong and we say, okay, this shows that people have started to behave differently, then we contact them, ask questions, and we try to intervene. All of those data and charts is about intervening with people so we could bring the person and treat the person as early as possible, not to be waiting until a crisis happens. We also ask well-being questions. Very simple questions about their mood, about their sleep, and about their health. How do they think they're either healthy or not? We contact them. We also use Alexa for some communication with patients with dementia and with carers, and they like the reminders. So we put automatic reminders. So Alexa said, please do your blood pressure. And then all the frequency comes and we get the data back from the person, and we could build up a history that this shows this is normal for this house, but every house is different. You can see that with all those graphs that we chart and everything that's done automatically, we could see that there is something wrong with this person. A persistent hypertension in this person suggested that the person was on blood pressure tablet for quite a long time, but now that the dementia is progressing, probably the person doesn't need that much of a blood pressure tablet. And if we do not intervene, the blood pressure drops, and then that's where the falls and everything else happens. So we try to bring the hospital and care to patients' home without asking them to leave to go see the GP or the hospital. So we try to bring everything back to the person and make them engage with their activity. They like, because they get feedback from us, they like that someone is monitoring them and looking at their data. So as part of this, we look at every aspect of the person. And you could see when the body temperature suddenly goes up, it takes time for clinical symptom to develop, that they need to go to see their GP. But because we get the data automatically on the day, immediate, then we know something may go up and maybe the person has some infection, maybe something else is going on, maybe we need to get urine sample, maybe we need to ask them to have blood tests. So everything done very proactively rather than waiting for crisis to happen. And that's the difference between the system we have to many other telehealth and telecare, because with other telehealth and telecare, it's about one range for everyone. It's about contacting them directly every day and asking questions. We do not contact them unless there is an alert and coming to the system. One of the major issues with people with dementia is about the diet and weight. So you could see that there's a weight chart there that they stand on it, and the data automatically transferred to us. They don't need to do anything. And this is where we get, is the person eating well or not? Is there anything we need to intervene? Is there any other thing going on with this person? And this is very important, that if someone has got diabetes, if someone may be developing cancer, all those information you get. People with dementia, they hardly go and seek medical condition. They only wait for the crisis to happen. But something that we've done that is very interesting. So far, we talked about the individual alert from one device and respond to that. But what we've done with the combined algorithm, so we looked at the behavior of the person, we looked at how often they go to toilet, we looked at their agitation, irritability, aggression, and we looked at their sleep pattern, and we put all the data together and we produced a UTI probability. With the UTI probability, if it goes above 6.6, that we think is the probability that is sensitive enough and specific enough, then we send a sample. We ask the person to send us a sample. We already gave them some bottles that they send us a sample. We check it, and if they have infection, they get automatically antibiotics and treatment. So from detecting some change in their presentation to point that they get the antibiotic, it takes less than 48 hours. Something that in normal clinic, usually a week, because people with dementia hardly come and say, I have some urine infection or hesitancy or burning sensation. They don't talk about this. They only get to the practitioner when they get to the point that they start to become confused or agitated or aggressive, and delirium starts. And by that time, it's too late. They need to go to hospital. So bed is occupied, and it takes longer and longer. So what we need to do, we need to have an integrated data service. We need all the data of the primary, secondary, and social services care to come in one platform. This is what we're now building. The platform that I showed you is the platform that we design and we use it, and we could expand it to other services. We need to work with live data. If we do not have the live data, then we use human resources to collect data. It means everyone needs to contact the person and ask them, or to go and see them. And all those journey and human contact is really pricey. And currently, majority of the health services across the world, they're not able to cope with this level of care that we provide. I think it's important to gather environmental and passive data, because it's so easy to look at the sleep mat. We've done a study with the sleep mat and clearly showed a couple of days before they started showing the COVID symptoms, their sleep pattern, the heart rate and temperature at night started to change. But the patient didn't even notice that there is anything else. But retrospectively, when we looked at those data, it suggested that something else is changing. So we could look at those data and be more careful about how to predict them. Predict the relapse is very important, because we want to intervene as soon as possible, not wait for crisis to happen. Sorry. And I think it's just the monitoring service, as I said, this is very new. This is the new model that we have here. And now we've got 2 centers, one in Surrey, one in west of London, in Hammersmith. And we want to expand it to other areas. So if someone is interested, we're happy to work with them. This is the service that alert the clinician. So the clinician, they do not need to arrange routine outpatient appointment to see people. They only see people that they need to see. And also the visit at home, it's only if it's required and if it's necessary. Otherwise, you don't need to go and see someone. Majority of the home visits, when the nurse or a doctor to go and see someone, when they walk in, they realize that, oh, I didn't need to come in, or it's too late, the person needs to go to us. And also the risk assessment for every individual are based on real data, rather than the way that we think maybe something going on. So we get the real data and we talk about it. This is my email. So if there is any questions or anything else, I'm happy to contact. I've got 5 minutes to stay here if we want to do a question and answer. Otherwise, I'm happy to end it at this point. Thank you very much.
Hi. To give a little bit of context of what we do, I want to take you to December 2019, because at that time, we had to go to the hospital with our kids. We have twins and they were 2 months old. And at that moment, they had a very acute breathing problem. So we went to the hospital and this is basically how it looked like. They were hooked up to big monitors with lots of wires. They had a lot of parameters that needed to be checked. And it was not super comfortable, but at least we were very happy that they were monitored. Now, the thing was, what was very noticeable and striking to me is, even though they were monitored, there's still a lot of overhead that was needed. Lots of nurses coming into the room, noting down these parameters on sheets, putting them in the computer. So they easily spent 1 to 2 hours per day just to follow up our babies. And luckily, everything was fine. And the first day was acute, but after a day, it was already better. Nevertheless, we needed to stay for another 10 days into the hospital just to be monitored, just to be sure. So we celebrated Christmas in the hospital, which was okay, to be honest. But it made me think about our healthcare system, because already a lot of people have been talking about it, that our healthcare system is really focused on acute care. You go to the hospital when there's something seriously wrong with you, and at that point there's lots of information about you, but at home there's very little information. And we have a population that gets older, we have a population that has also a lot of chronic conditions, so our healthcare system is not optimized to do that. The first day we needed to be in the hospital, but the other 9 days, it would have been much better if we were able to stay at home while still being monitored. And the problem that we see with our healthcare system is becoming more and more expensive. So this needs to change, and this is actually changing. We see that healthcare is shifting towards a system where you still need hospitals, you still need specialized hospitals that focus on urgent things, emergency room, operating room, intensive care units, but all the monitoring that will shift more and more to the home. So it's more comfortable, it's cheaper, but also for longer periods of time. So it brings much more value to patients. And this shift is happening, but in order to do so, we need other tools, or the hospitals and the healthcare providers need other tools. They cannot do that with these bulky equipment where there's lots of overhead. You need to go to a system where you have very comfortable patches that measure same information as in a hospital, but in a home environment. And this is actually what we do with Byteflies. So this is our oldest daughter. And with Byteflies, we actually have a telemonitoring platform that allows, or that brings the tools to doctors, to specialists, to be able to follow up patients in a home environment. And how we do that? Well, that's with a platform. On one hand, we have a tool set of building blocks going from devices that measure vital signs. So if you see on here, this is our Byteflies sensor dot, which is basically the big monitoring device in the hospital. We squeezed it into a small device. It measures the different parameters, but we also have software blocks. We have analytics building blocks, AI, visualization tools. And with these building blocks, we can make specialized monitoring solutions. Specialized monitoring solutions, for example, for cardiac patients. And you have a lot of people with some cardiac condition, especially if you get older, maybe if you had a stroke, very often underneath there's some heart rhythm problem that is causing that. So with cardiac care at home, we can follow up patients from a couple of weeks to a month to be able to detect these anomalies. And for epilepsy patients, we put these building blocks together to follow up patients with epilepsy, because it's a pretty big problem that these people that have epilepsy, they are put on medication, but very often the neurologist doesn't know whether tools are working or not. So with EpiCare at home, they can send them home, follow them up from a couple of days to a couple of weeks to be able to adjust the care. For sleep as well. And so these are a couple of applications. And a very important moment for us was COVID 2020. I think it has been pivotal for a lot of people here as well in the virtual room, because at that moment, when COVID hit, we noticed that very acute and hard pressure on our healthcare system. And we were already working for 5 years with Byteflies. We were already building our platform. We were already offering these tools to different players, also to pharma companies, to be able to monitor patients at home. But the moment that COVID hit, we immediately had the feeling that this is a pivotal moment for healthcare. We will look back in 30 years and we'll see that 2020, the year that COVID happened, is the moment that healthcare fundamentally changed to go to this transformation. And at that moment, because we already had the platform, very fast, we stepped together and we reached out to a lot of partners and we said, okay, we have building blocks, we have technology, we think we can do something, let's work together and let's help our healthcare system. And that's why we launched COVID Care at Home, because it was a very big problem, but also not to do it too extreme, but relatively simple from a technological point of view. Because basically with COVID, it was such a severe disease, but the moment that it was happening to someone, either you are relatively safe, but if it gets a little bit more extreme, you go to the hospital. But if you're in the hospital, there's basically 4 parameters that are measured a couple of times a day. That's your heart rate, respiration rate, blood oxygen levels, and your temperature. And a lot of people needed to be monitored, because if it goes bad, you really need oxygen, you really need to be worst case intubated, to go in a coma, to be able to help you and to give you oxygen to hopefully recover. But in a lot of cases, these patients in the hospital beds, they were just being monitored for a couple of times per day. And we said, okay, our hospitals are crippling. There's too many people in the hospital. A lot of other care needs to be shut down because all the beds are filled. Can't we just keep these patients in their home bed while still being monitored? And that's what we did. And so basically, we launched COVID Care at Home, very simple solution. Instead of the patient being in the hospital, being followed up there, they were able to send them home. And at home, they had a COVID Care at Home box where they had tools to measure these parameters: temperature, respiration rate, breathing rate, the heart rate, and SpO2. And they measured that a couple of times a day, and that data is then sent to the doctor. And the doctors, they had a dashboard. So it seemed like they were in the hospital, where they were still in their home environment, where they could actually follow up for patients, like what are these parameters? Is there an acute problem? Do we need to call them? Do we need to hospitalize them? Or are they safe and are they just being followed up? So they had a dashboard where they could follow up the patients in the virtual hospital, if you want. And this is another dashboard. Basically, if they want to look at a patient, they can click on them and they can see how these parameters evolve over time. They could see how patients are recovering. And that was a very important part, because actually in a short period of time, because we worked together, we built a care at home solution on our platform. We piloted it. We worked together with a lot of hospitals, because the biggest challenge was not to have a technical solution. The biggest challenge was to offer this solution as a tool to specialists. How can they interact with it? How much time does it take? Does it create a lot of overhead? Because it doesn't reduce the work that they need to do. It allowed them to follow up many more patients. So for them, it was very important in order to make it very workable, in order to make it feasible, that it was very intuitive, that it easily integrated into their workflows. So we worked very closely together. And because we did that, we were able to go very fast, and we reached more than 30% of Belgian hospitals. And we kept a lot of patients outside of the hospital. We saved thousands of hospitalization days. And for us, it was also important that we got the support of different players, partners we already had, but also you have organizations like EIT, a European organization that supported with money, with network, different organizations as well, like the city of Antwerp, that really boosted us. Because when we started, there was a big problem. We had a solution, we integrated it, but another problem was there was no financing for it. This transformation in healthcare also means we have to look at new ways how these technologies, but also how these doctors, how these different players are going to be paid. It didn't exist yet. People talked already about telemonitoring for 10, 15, 20 years, and there were a lot of ideas, but there was very little framework of implementation. because we didn't have that like a framework, we really needed the support of different players. Now, there was no framework at that moment, but the thing was, there was such an urgent problem that there was a lot of, let's say, a vibe of animosity of let's do this. This is a moment where we can help today with this acute problem, but where we can also define how healthcare will change in the coming years. And actually, while doing it, we, after a couple of months, we negotiated reimbursement with the government for remote monitoring. And it was at that moment also from the government point of view, they said, let's use this crisis to help this current crisis, but also to learn how we can translate this for the future. Because yes, today we have COVID, which affects a lot of people, mainly older people, but there's lots of diseases, there's lots of chronic conditions where fundamentally we need the same solutions. And we need to learn today how we're going to pay that, how we're going to integrate with all these stakeholders, and we're going to learn this by doing it. And so also in the scope of working together with all these hospitals, working together with all these stakeholders, we learned a lot from each other and we co-created different features. If I look back at this dashboard, you know, we started with a dashboard that looked totally different. And then we were measuring the first patients, but we got feedback from the doctors that said, this is great. But then nurses started saying like, this is not good for us because we look in a different way to that data. We got feedback from users. We had patients who were being followed up, patients ranging from the age of 20, 30, but the bulk of the patients were 70-year-old, 80-year-old, 90-year-old. They interact in a different way with these digital tools, with cell phones, etc., than young people. So we learned from them how we needed to build our tools to be intuitive. And an 80-year-old that is healthy also interacts different with these tools than an 80-year-old who is sick. So for us, implementing it, building it bottom up, and going into a lot of patients, to a lot of hospitals, but also with our way of working, where we try to be very lean, very agile, work very close together with all these stakeholders, allowed us to get these results. And that's a very important message that I want to bring here as well, is we at Byteflies, we are super excited to work in this space because we believe that in the next years and next decades, this is going to transform healthcare, but this is not a one company mission. We need to work together with big players, with small players, with startups, with established companies, with the government, with the hospitals, with the healthcare providers. All of us, we need to work together to bring these solutions to patients, because it's not a one company mission, but it's also not about technology. It's also not about companies. It's about the people. It's about the patients, the family members, etc., that you want to help. And in order to do that, we really need a collaboration and an ecosystem to work together. So that is where I want to conclude my presentation. I want to say thank you to everybody. Of course, go into the Q&A. I'm very happy to discuss with you what your experiences are. And of course, on the other hand, take questions. And before we go there, I want to end there that I'm very excited to see what is happening today. And even though there are moments of, a crisis like COVID, it's also encouraging to see that it often brings the best into people to change things. Thank you very much.
Thank you, Hans, and thank you for your time and presentation. And so we are taking questions from the floor now. And actually, I think your presentation means so much to us because it's our last one, and you have left a very hopeful mark to us. And there is one question coming from the floor: is the healthcare industry is generally taking a risk avoidance approach. How was your experience in Belgium or the partners that you work with when how to overcome this barrier on risk avoidance behavior?
It's a very good question, and that's Also, one of the reasons where we saw that because of a crisis like COVID, where even in a risk-averse environment, we were in a situation where a lot of people were actually dying. Were actually dying because hospital beds were being flooded, and the healthcare system was really getting to its edges, and you can argue that in that situation there was a lot of risk for a lot of people at that moment. So actually implementing these technologies reduces the risk at that moment, because you can monitor much more people in their home environment. You can actually make sure that the beds are not flooded, that capacity is not being blocked for other people. At that situation, there were people that needed care but didn't get it. So because there were no hospital beds, or they were, getting into lockdown. Also, people who didn't have COVID, people with other diseases, at that moment they needed to be put on a waiting list. So, a risk is not a black or white, situation. It's a spectrum, and it's at these situations where the situation is more extreme that it's much more easy to really implement those new technologies. Because beforehand, what we saw pre-COVID is that these discussions, for example, risk, etc., they were also always a reason to say, let's not try it yet. Let's fully de-risk it. But it's impossible to fully de-risk it. And if you think about it, you actually already bring much more value in a situation where people are not followed up. It's much more risky. But you need to start implementing it to learn it, that there's actually less risk related to that. But it's change management.
Right. Thank you. I think you have mentioned, no matter where you are now, like our audience probably coming from different parts of the world, every corners of the world, we have seen the very drastic situation back in probably the fifth wave of the COVID, and how that is we need to take care of it, and also at the same time ride on the opportunities that we actually drive us to better outcomes, for no matter for alleviating the healthcare system or also helping the people who are really in need. I think there is one question from the audience is, what advice would you give to encourage the adoption of such telemonitoring solution by the doctors or nurses, despite the fact that the workload is nearly the same?
It's a very good question. What we see or what we experience is not only during COVID, but also with the solutions we offer now to doctors. And like we have cardio care and epi care to follow up cardiac patients and epilepsy patients. Is that we explain what the value is to the patient as well. And we very often see that there's lots of willingness from doctors to look at new solutions. They understand that if I follow up a patient at home, I get more information, I get more insight. It can make my life easier as well, to give the right advice, to switch medication, to bring them to the hospital if there's extra need. So it very often the discussion we have with doctors is not about the value. And they can argue, they can see the value as well. Longer monitoring will help them. The biggest discussion is on the operational overhead. How much more work will it cost me? And there is very important to really show and to really start on one patient or two patients, to really give them confidence of, very often when they think about technology, they think about, it's going to create so much extra work for me that I don't want it. It's not about the value, it's about the overhead. So you need to show that it actually also brings down the overhead. The third thing, what's very often the elephant in the room, and that's where also governments and payers come in, is how will people get paid? And also, how will doctors get paid? Every country has a little bit of a different payment system, but in a lot of countries, it's organized that if patients go to the hospital, then the doctor can get paid. But if they stay at home, the doctor doesn't necessarily get paid. So it's very important as well to give confidence to doctors and hospitals that the government and the payers give a guidance on where this ecosystem goes to and how the payment will be organized, not only today, but also in the future. Because there's a lot of willingness to try it. There's a lot of willingness to adopt it, but there also needs to be a view of how it's going to be in the future and what's going to be my role in it.
Great. Thank you for your feedback, and also thank you for your input as well. Thank you for the presentation, and we would love to see you like in person one day. And thank you for introducing Byteflies to us. And take care and goodbye.